Thanks. Let me figure this out. Morning. Great pleasure to be here. Again, I've been here a couple times in other meetings, and if you think you're the zebras in the room, wait until you hear about multivisceral transplant. Then that's probably the big zebra, because when you look at, can you hear me? Oh, okay, maybe I should take this off. Is that better? Okay. So I was saying, if you think you're the zebras in the room, wait until you hear about multivisceral transplantation. But interesting enough, you know, when you use the word multivisceral or intestinal transplantation, even the physicians, when you go around the country, they did a survey. One of the transplant societies did a survey many years ago, and less than 50% of the doctors actually knew that this type of transplant existed, and of those, very few actually knew what are the results. I mean, how can you change all the organs on somebody and have them survive later? Also, very few centers in the world perform that type of transplant. I think there is a great role for multivisceral transplant in neuroendocrine tumors. And basically, the question is that can we reset the clock? So once we have disease spread to your abdomen, could we actually reset it and remove those organs, replace with healthy ones, and perhaps then treat with all these beautiful treatments that we're looking at it? Maybe we have a window that we don't have tumor, and then we can prophylactically prevent this disease from coming back. What we see now is that we only get the patients when it's very, very advanced disease, and probably 9 out of 10 are not even candidates for transplant anymore when they come to see us. So I think we need to see, and hopefully after this talk, you'll see the role of multivisceral. And I had great help from some of the oncologists here. Eric and Dr. Woltering send me patients for these transplants that we've done, several of those cases now. And you will see that the results are probably much better than you would think. So this is just an interesting picture. This is the first human liver transplant. It was performed by a surgeon called Thomas Tarso in 1963. They had 4 patients that died, and they used probably 200 to 300 units of blood. And those days you didn't have electrocautery, you didn't have many of the things that we have now. And a good liver transplant will be 15 hours. A bad liver transplant will last 30 hours or more. But these people kept pushing because they thought there was a role for this thing. And everybody said, why are you talking about? You know, we have other treatments, or why you're investing on this. And today, we have more than 90% survival for patients that receive a liver transplant. So then you see that kidney transplant, what did the nephrologist say when they come up with liver transplant? Leave them on dialysis. Why are you doing a transplant? Today, nobody wants to go on dialysis. You know, they get a liver transplant. Actually, they get a kidney transplant even before they go on dialysis, because we know the survival is much better and much longer if you get the transplant. When you talk about tumors, people that had liver cancer. So people that had primary liver cancer and were cirrhotic many, many years ago, people tried to do a transplant on them. But the problem was they did it when it was too late. And then a lot of people had recurrence and they shut it down. They said, we can't do liver transplants for cirrhotics. And then in Europe, a surgeon by the name of Mazzaferro said, wow, we're doing when it's too late. That's why it's not working. We should do it when the tumors are small. And if you look at it today, what is the standard of care for people that have cirrhosis and liver cancer? Is transplant. There's more than 90% survival compared with less than 10% survival when they were doing when it's too late. So we need to find the timing to refer patients for this transplant. I think it could be very helpful if we find the timing, not when it was too late. This is the first liver transplant that actually was succeeding in Pittsburgh, and we use much less than that. For you to have an idea, those days they take 15 hours to do a liver transplant. Today in Miami, we take an average of 3.5 hours to do a liver transplant. So things have changed a lot from the old days. Multivisceral transplant we can do for adults. This is a very interesting case. Kids get in trouble too. And this is a 5-day-old donor that we transplanted to a little baby that was born without the intestine or with severe disease in all the abdominal organs. So technically it has been settled. I think all the issues that we had in the past, most of those patients could not get through surgery. It's extremely rare they will lose a patient because of the operation. So we can basically tailor the transplant according to the patient needs. If you don't have an intestine, we can replace the intestine. We can replace the liver and the intestine. We can replace the liver, the intestine, and the pancreas. And we can replace everything, the liver, the pancreas, the stomach, the intestine, and the colon. Or if the liver is okay, we can replace the stomach, the pancreas, and the intestine. So we have figured away techniques that we can actually tailor the organs according to the patient's needs. So those are all the many phases of an intestinal and multivisceral transplant. And this is 1987. It's not too long ago when they performed in Pittsburgh a 3-year-old girl that was born without the intestine, and she had liver failure, and they performed this operation. The same surgeon, Starzo, replaced the liver, the small intestine, the pancreas, and parts of her stomach. There's a sad story after this. This girl lived for a few months, and she always had the same nurse that was taking care of her. And she developed disease after she had a tumor, and she died. And at the same night that she died, the nurse that was taking care of her was driving home and crashed the car and also died probably 2 or 3 hours after she died. But it was a great moment in history where you could finally replace all the organs in somebody's abdomen. And this is an interesting case. That's the small guy in 2003 when I moved. I trained in Miami. I went to Indianapolis, and now I'm back in Miami. But the small guy was only a few months old when he had a terrible disease to his intestine. He was going to liver failure, and I did a multi-organ transplant on him. This is a picture of him playing baseball, healthy, no ostomy, no G-tubes. This is 07. Now we're on 14. Now he plays soccer for his school. He's 14 years old, and he continues to be very healthy. So what do we do in intestinal multivisceral transplant? Well, the classic indications is not for tumors. And that's why we run into trouble, because very people associate these transplants with tumors. Actually, very few people associate transplant with tumors because they say transplant, immunosuppression, it's probably not going to work with tumors, but it's not true. So the classic indications are when you get in trouble and you don't have your intestine and you need parenteral nutrition. Now, the parenteral nutrition, the nutrition through the veins, can cause trouble. It can put your liver in trouble. You can have sepsis, infections, or you can have thrombosis. But that's not all. We can use those for other things. For example, if you develop thrombosis of all your veins, neoplastic disease, neuroendocrine tumor is not the only indication for it. We have Gardner's disease, we have slow-growing tumors of the abdomen. There's so many of them. And they're non-resectable by general surgery because they are stuck to the big vessels, or after you resect, you will have no intestine, you will have half of your organs will be gone. So we can still resect them if we replace them. The other thing that we can do is something called autotransplant. Is that, well, you can't resect those tumors because either you're going to cut the blood supply or the patient's going to die with the transplant. Well, we can do something like we can flush those organs with a cold solution. You can take them outside the body. Then you can do the resection when the patient will lose no blood, and then you give them back as a transplant, but the transplant comes from the same patient, so you don't have to use immunosuppression. So those are all techniques that are used by transplant surgery that is not possible in a regular transplant surgical environment. So what is the downside? Well, it requires a big operation, and you're going to have to take immunosuppression, but actually is the only chance for cure. I'm not talking about palliative therapy or prolonging your disease. I'm talking that there's a potential role if we develop the right therapies pre and post-transplant. Again, you reset the clock and then you can apply those therapies. I believe there is a chance for a cure in many patients. So this is how the graph looks like. This is an isolated intestine. As you can see, there's a little bowel plugged into the cave and the aorta of the patient. There's many ways to do the vascular work. This is a modified multivisceral transplant. People with disease in the root of the mesentery. We did have patients that had neuroendocrine tumors involving the SMA, or is non-resectable, because if you resect, you're going to take all the bowel out. Well, you can do that if you replace it. Sometimes it's around the pancreas or around the root of the mesentery, but the liver is free. So you can still preserve the liver only and then resect all the nodes and all the organs that are attached to the liver. And this is the big one, the multivisceral transplant, where we only keep the esophagus and the final part of the large bowel, and everything else is replaced. It's like taking your car to the shop, and they say, you know, too many parts are not good. We should just give you a new car. So this is basically get a new one. This is the new car. And why is it effective in an oncology? If you look at this picture, it tells more than 1,000 words. Here, we have basically resect all the organs, and it's very important. We take all the nodes surrounding the organs. And interesting enough, when we look at those patients with the neuroendocrine tumors, most of them will have negative scans in those nodes. And they will say, wow, I had my pancreas resected, and I only have disease in the liver. And when you go back to pathology, there's a lot of cells on those nodes. So when we take them out, is the only chance that we actually can achieve cure, because yes, we remove, I think the best treatment for neuroendocrine tumor is still surgery if you can accomplish that. So yeah, we can accomplish that in most people if they come on time, if they don't have disease outside the abdomen or disease implanted in the peritoneal cavity everywhere. So if you are on the right time, I think there's a good chance you can do some good work for those patients. And this is after. I know it's gross for you, especially for the patients, but actually if you look at a book, this is perfect. You can't tell that this is a transplant organs. I mean, you have a very healthy intestine. These days, we even transplant the large bowel, and we stop even doing ostomies. So after the patient is transplanted, he has no G-tube, no ostomy, and 2 to 3 weeks later, they start eating pretty much regular food. This is a baby. We can go as small as sometimes. You see the whole thing fits in the hands of a nurse. And this is after we implanted them and the small kids. This is a very interesting story. This is a man that had neuroendocrine tumor of his bowel, and he was incasiating his SMA. And he went to one of the general surgeons in our hospital, and she said, look, if I take your tumor out, you will have no intestine. So she called me and I said, look, this man is saying he wants it out. He doesn't care. He wants it out. He doesn't want this tumor there. So, okay, he took the bowel out. And then he said, well, I'm okay. I can live with short gut syndrome. So 3 months later, he comes back and says, look, I can't live with short gut syndrome. I really don't like it. I can't eat everything. I'm vomiting. I have terrible diarrhea. This is worse than the tumor. I said, okay, well, maybe we can replace your bowel. And he said, okay, let's go. So by that time, because of the diarrhea they had for many years, he also had kidney failure. So I gave him a kidney and a bowel transplant. And, you know, I follow him, but I kind of forgot. And he told me before he left the hospital, he said, if I'm alive 3 years from now, he had very long hair, I'm going to cut my hair. Okay, 3 years later, I got that picture. And, you know, he cut his hair. He drives his Harley Davidson. He's probably 8 years after that operation now. He was 67. He's probably 74 or 75 now. And I rarely see him. You know, you can see a little bit of the scar in his abdomen, but he's doing really well after that journey. So what are the patients that we end up getting for multivisceral transplant? It's usually patients that have extensive disease with liver mets, patients that have involvement of vital blood supply vessels, the mesenteric root. And usually we don't like to have patients that have disease outside the abdominal cavity for obvious reasons. I think you have to be able, the organs are a very scarce resource. So it's not that we can give organs to everybody if they have disease everywhere. So this is an attempt to cure the patient. So it is indicated, but for selective patients. Most of the patients have failed other therapies, local ablation, radiation, you name it. Sometimes when we go inside these cavities, they have 20, 30 operations, and we go to do the transplant. So this, I'll give you an example. This is one of the first few patients that we had. 40-year-old a male with an insulinoma. You can see the size of the tumor was actually pushing the stomach. He couldn't eat anymore. I actually had to resect a piece of his aorta. It's very interesting because the other problem that we have is insurance companies. When you say multivisceral transplant, they say, what? For what? And then it takes us months sometimes fighting. And unfortunately, some of them don't ever approve those treatments. But this was a great deal. We operated on him. We took the tumor out, and you know, he's 8 years, almost 9 years out now, and he's free of disease. he didn't get a lot of treatments. He was not as weak when he came for transplant. And this is how the tumor looked like. You can see this is huge. And it was pushing in his stomach. And actually there's a piece of aorta inside here. It was a major operation, but he's doing really well. Here you can see. So this is another patient, very interesting. He was a 32-year-old man that came to the ER and he was in liver failure. He had a glucagonoma, Zollinger-Ellison, and he was dying because he had no liver left. It was a fight, to get him through it. We admitted him and we did a multivisceral transplant in 2008. So you get somebody that's dying and we reset the clock. And at this moment, I still don't know, and that's something that we need to get together, that the people that are working on this, and say, do we need to do some therapy after? Do we need then to give them prophylaxis so they don't have the tumor back? Well, he lived for another 4 years, and then he had 2 lesions in the liver and 1 in the spine. We radiated the spine. He is on, there is a great drug, Afinitor, everolimus. It's a great immunosuppression. So we can use that to immunosuppress the patient and to prevent the disease. So now we're in 2014. This guy is working still. He's a farmer. So you got somebody that was dying in 2008, and 8 years later, he's still doing very well. So again, I think we do have a great opportunity. Those are extreme cases that we get. Can you imagine if we get the ones that were a little bit earlier? And this is how the tumor looks like. Actually, this is not his. This is another patient. But this is the liver of that patient that had so many lesions from neuroendocrine tumors. So you can imagine, I think there's no chance you can go long-term with a liver like this. When you get to that point, I think you're just going to go down. There's no way at some point it's going to fail. So we had great advances recently. Now we have the gadolinium scan, and I think that gives us more information to find known primary disease, small volume metastatic disease. I think in the beginning we made a few mistakes. We transplanted people that had metastatic disease somewhere, and some of our recurrences are from that. And also, I think we can increase the ability to measure the response to treatment. The way I see this in the future is, okay, we take these organs out, they're full of tumors, we give it to these guys, they analyze all the cells, they see what kind of therapies would be great to do, and then from that time, maybe we can do prophylaxis, maybe we can do a vaccine so the tumor doesn't come back. Or then we can use those therapies when we do not have, in theory, disease in your body. I think that's what would be the role for multivisceral transplant. Here you can see the differences in a regular CT and the GAD scan. I mean, you wouldn't see it if you didn't use the gadolinium scan. Bone disease, see the difference. Here you can see it, here you cannot. So we have our patients get a gadolinium scan before we do these transplants. Maybe in the future, if we do have really good therapies, we could do a multivisceral transplant and control metastatic disease. But at this point, with the scarcity of organs, we really need to be selective and on the patients that we are doing this. Here, see the difference. This patient had extra-abdominal disease, would have made a mistake before the gadolinium scan, and I bet we made a mistake before transplanting some people that had extra-abdominal disease. Again, another example, and you'll hear more later from the other speakers, but it has come to actually in the last few years, I bet you will be a lot more precise on the patients that we do those transplants. Some of them had a lot of surgeries. I mean, if you look at this, this is really a very difficult patient to do surgery. You cannot even identify what's what because of the many surgeries they had in the past. So I do think sometimes we get them late. So what about liver transplant? I remember I watched Steve Jobs died after a liver transplant. I tried to call him many times, but he wouldn't take my phone call. You know, the 3-month mortality for liver transplant is 10%, the 5-year survival is 52%, and of the 52%, survival-free of disease only 30%. So for the reasons I just told you, when we remove those organs and we take all those nodes out, in most of the patients they're positive, and even though you don't see them in the scan. So you do a liver transplant and you had disease in the pancreas, the disease didn't fly to your liver. it passed through the tissues. You know, it might go to your blood, but it's hard for me to imagine that you have a disease somewhere in your gastrointestinal tract and then it just, as a miracle, shows up in your liver and you don't have cells in your lymph nodes. So, most of the patients, when we look at the pathology, they do have positive cells. So this is a study, it's a very large study looking at 213 cases. And remember those names, the 5-year survival is 50% only and the survival-free of disease is 30%. Now, it's true that when patients get to the stage when they're sent for transplant, they have very advanced disease. So I think we have to change our mentality and look at transplant as just the final miracle way. No, it should be applied differently, probably much earlier in the treatment of these diseases. Here, just the series of patients. You can see, except for one series that has a good 5-year survival, most of them, if you look at the average, will be about 50%. So what is our experience? I started doing those cases in Indianapolis in 2004, and we've done 14 patients there. I've done another 2 patients last year in Miami. So we have 16 patients, 4 tumors type. Most of them were carcinoid, insulinoma, gastrinoma, and VIPomas. The median follow-up is 55 months, 12 to 19 months, and 12 out of the 16 patients are alive. Now, if you think about it, that I'm getting the people that are at the end, you know, basically dying from the disease, and still we have 12 of the 16 patients alive. If you're 65 years old and you live in a third world country, your chances of dying are higher than if you live in the United States and you have liver cancer, just because you'll die from other causes because of your age. So we will never have 100% survival because people die. So I think we have recurrence in 4 patients. One patient had recurrence in the liver, died 10 months post-transplant of liver failure. Now, that was my first mistake. This is a 40-something-year-old man. He had 4 kids. They tried to resect his liver. They tied his hepatic card. He was on liver failure. I knew he had disease outside, but I couldn't just not do it. And we did it, and we gave him a chance, but he had too much disease. Another patient had mediastinal lymph nodes when we did the transplant, and we thought, you know, it's just a couple nodes, maybe we can do it. He had been through a lot of treatments, and he actually didn't die from the transplant. His bone marrow was too weak from all the chemos and treatments that he received, so he had neutropenia, and even though I took him off immunosuppression, he was not even on any drugs. He died from some type of bone marrow aplasia, 17 months post-transplant, and he had a small lymph node in the mediastinal, 2-centimeter mediastinal. So he didn't die from that. He died from being very weak. And one patient, the one I told you, the 32-year-old, the guy had a couple of mets, but he's stable. And we have one patient that had recurrence recently in the liver and the bone almost 3 years after transplant, and he's stable now under treatment. We lost, the patients that we lost, one was sepsis, he got an infection, and one, very hard to predict. He survived the operation, and then later he was getting a blood transfusion, and he had what's called TRALI. It's a deadly reaction to the blood. So he died from the blood transfusion. So it's a very unfortunate event. But if you look at all those patients, if we had identified these 2 patients, and I should not have done the first 2, and if we exclude those 2 patients, our 5-year survival goes up to 90%. So that's very high for some people that are getting this treatment very late in life. Recently, we have changed the immunosuppression protocol, and actually most of those patients, after a few months, they're taking everolimus only, or a little bit of steroids. So this drug is very good because it's an anti-tumor drug, and also is an immunosuppression drug. It has a strong anti-tumor effect, especially with the PNETs. So the experience with multivisceral transplant shows 50% less recurrence when compared to liver transplant, and a 30% advantage after 5 years when compared to the data from the liver transplant series. Why? Because of that. Because that's the only operation where we can do this. We can really take all the tumor out, and we can take all the nodes out. This is the renal vein, this is the vena cava, and the aorta is down here. So here, in a normal patient, you will have a lot of celiac ganglia. you have all these lymph nodes, and after we take the organs out, we make a very careful dissection and remove all these organs. And it's not as blood as you would see. See, it looks dry. So I think I left some time, if somebody will talk about it, but I think it's a viable option for patients with unresectable neuroendocrine tumors. I think we need to get together and find out the right time to do those transplants, and do we need to do some therapy after? I think there will be, I think we can get this to where the treatment for liver cancer is. Once we have 100 modalities of treatment for one disease, it's because you don't have a good one. You know, if you have a good one, that's what you do. So I think there is a role for multivisceral, and it should be used not as palliation. This is not to be used as palliation, not the last miracle treatment. It's to be used and as an attempt to cure those patients from this disease. And this is a very interesting case. This woman had disease to the mesentery. She had complete bowel resection, she had liver failure, and she was going to hospice. This is in 2005. And a few years later, she's getting married. We're almost 9 years after the transplant. That's her kid. He was a baby on those days, and now he's about 9 or 10 years old. And she is working full-time, and she is very healthy, a productive member of our society. And this is just for fun now. I don't know if this video will play or if you can play from there. Don't know. Can you guys play it or from there? No, this one. This is a patient that we did last year that had advanced disease, and this is 4 months after the transplant. He showed me this video where he was boxing in the gym. It's very impressive, actually. He would probably kill me. So he is a year out now, and he doesn't have any disease, and he looks really good. And finally, I think just for fun, you can still have a little bit of zebra on you, but maybe we can replace the rest. And thank you so much.